Hello, welcome everyone. Thank you so much for joining us today. We're really glad that you are all able to join us. I'm Trisha Martinez, Senior Director of Clinical Transformation at Glooko. And in my role, I work closely with health systems to help clinical, operational, and IT teams to design and scale diabetes workflows that reduce burden, improve visibility of diabetes data, and ultimately support better care delivery and outcomes for patients. I'll be moderating today's conversation. Before we get started, just a few quick housekeeping items. All microphones will be muted during the session. If any questions come up, and we hope they do, please use the Q&A feature and we'll reserve time for live Q&A at the end. I'm excited to be joined by two leaders who bring hands-on experience from very different health systems, but who have solved remarkably similar challenges. First, joining us from San Diego is Dr. Carla Demeterco-Berggren. Carla is a board-certified pediatric endocrinologist and a clinical professor of pediatrics at the University of California, San Diego. She also serves as the director of the diabetes program at Rady Children's Hospital. In her role, Carla focuses on driving meaningful improvements in clinical workflows and patient outcomes, particularly in complex pediatric diabetes care. She and her team have partnered closely with Glooko to adopt the Glooko Enterprise Solution, integrate diabetes data directly into the EHR, and expand connected care models. Carla brings a clinician's perspective on what it truly means to have the right data at the right time during patient visits. We're also joined by Chris Dallas from Michigan Medicine in Ann Arbor. Chris is an operational leader focused on developing and implementing initiatives across diabetes and endocrinology to streamline treatment processes, improve outcomes, and optimize the patient experience. He's led multiple large-scale projects at Michigan Medicine, including the implementation of Glooko, helping bring innovation, standardization, and scalability to diabetes workflows across the organization. Chris offers a critical operational lens on what it takes not only to implement EHR integrated workflows, but to make them stick and scale across teams. Carla and Chris, we are thrilled to have you both here today. Thank you so much for joining us. To kick us off, I'd like to start with just a broad question for both of our panelists, and it's very broad. What excites you the most about where diabetes care is headed right now? Carla, we'll start with you, and then Chris, over to you.
Thank you so much. First of all, hi everyone. It's a pleasure to be here. I'm grateful to be able to share our work, and I'm very looking forward to a great discussion today. So I think what excites me most about diabetes today, number one, is that we're stopped being just reactive to type 1 diabetes. With all the advances in early detection, with auto-antibody screening, we can now, predict and monitor and decrease, acute complications such as diabetes, ketoacidosis, and in some cases, we can even intervene early and use disease-modifying therapies to delay the progression into symptomatic disease. And another very important point in technology is with the advances of continuous glucose monitors and automated insulin delivery systems, we are helping not just decreasing or increasing safety and decreasing the burden for individuals living with type 1 diabetes and their families, but also we have access to real-time data. And having access to real-time data allow us to provide personalized diabetes care. So I think all those items together lead us to a much better care to individuals that living with type 1 diabetes.
That's great. Thank you, Carla. I think anytime we can prevent patients from entering the hospital is an incredible win. Yeah, great insights. Chris, what about you?
Yeah, hello everybody. Also excited to be here and share what we've done and have a good discussion from that. But yeah, what excites me the most is when I started working on kind of diabetes tech projects in 2018. the growth that we've seen in the market has just been exponential since then. Every year, there's more and more coming out. Seems like almost every month now, more and more coming out, from pump therapies to CGMs to looping systems to the software that gathers that data. So having all that competition in the market, things getting better every year has led to and continues to improve not only the care that we can provide, but makes life easier both on the physicians and the patients. So that's exciting to see, and we're excited to see where it continues to move.
Yeah, that's great. I know that's something that we are certainly keeping our pulse on as well. I think especially since the ADA guidelines have changed. I know you probably are both familiar with some of the updates, but I think in the past the ADA had it was a lighter recommendation towards the use of CGMs, and I think now we really are seeing much stronger recommendations, especially with the adoption of CGM and Carla, to your point, the data that it helps provide so that we can be a lot more proactive. It's certainly something that we're seeing and we're excited about as well. Moving forward, I want to just share a couple of observations that I'm sure many of you on the call will as we kind of kick off our conversation here. Um, First, we've never seen more data than we are seeing right now with diabetes. But I think many of our teams are stretched pretty thin. We know that CGM adoption continues to accelerate. We know, Chris, you mentioned this, device data volumes are exploding. There's tons of new devices coming out on the market. Expectations around access, coordination, outcomes, all of those things are rising. And at the same time, I think our clinicians, educators, ops teams are spending way too much time having to figure out how to manage all this information, managing the administrative tasks instead of really caring for patients. And at least what we found, the challenge isn't necessarily access to data, but it's how you access it and when within the workflows. So moving into our conversation today, really what our goal is to think about what happens to care, what's possible when teams no longer have to search or hunt for that data, but when it becomes readily available. And so we're excited to hear how you have both operationalized this in your systems. For a brief overview, for those of you on the call who may be less familiar with our EHR integrations, I just want to touch base briefly on them. And then Carla and Chris, I'll give you both some time just to high-level overview about the types of integrations that you have with Glooko. So first, we have our Glooko patient portal for professionals. It's affectionately called our one-click access, but that allows providers to access Glooko directly within the EHR and is also available within the Epic showroom. Single sign-on using your organizational credentials, we always recommend that because we do want to make it as easy as possible for our providers. Both the PDF and the flowsheet statistics integration are triggered by the same mechanism to automatically pull in data directly into the EHR. The flowsheet statistics does offer the convenience of the discrete data, which we're going to talk about in a little bit more detail. And then finally, Glooko allows users to create patient accounts using data that comes directly from the EHR, simplifying that process for patients. So Carla, if we'll start with you, if you could just tell us a little bit about how long you've been using Glooko, and just briefly about the integrations that you have.
Of course. Just before 2020, we started work with Glooko, and it was immediately before the pandemic. And at that time, we didn't have integration yet with the electronic health record. So basically in 2020, we're able to upload the devices to Glooko, but immediately after, the pandemic, that we have to be forced to move into telemedicine, we realized how powerful the integration would look for us because we felt all the pain points during that pandemic and having
Yes,
to do
I'm feeling them now, like reminiscing about the pandemic. Yes.
Yeah, so I guess I can say the silver lining was really driving us and push us through integration with electronic health records here at Rady Children's Hospital, and that was really a game changer for everyone. So
that was an incredible time of innovation wasn't it? Like rapid innovation. Yeah. Yeah,
And
please
I need
continue.
to give a shout out to our team here, the IT team in the, our electronic health equity, electronic health records team, because they beat a record. We move everything in person to telehealth in 8 days, the whole
Wow.
organization. So it
Wow.
was
That's
absolutely
incredible.
incredible. Yes.
Yeah. Thank you. Chris, let's move to you. Just tell us kind of about the same, how long you've been a customer and what type of EHR integrations you have.
Yeah, so when I first started in 2018, one of the first priorities we had was to find a as much of a device agnostic solution as we could for our intake process for diabetes data. So that led to a large RFP and ultimately started working with Glooko in 2019. Um, and then from that, we immediately started working on the more of the in-clinic workflows and integrations. As you see listed here, and compared to the last slide you have, or two slides ago, I believe, we utilize almost the full suite of integrations. We have the one-click, we have the in-clinic PDF and flow sheet, the on-demand flow sheets and PDF, and then we're currently resourcing to add the create the patient account. So hopefully that'll be done relatively soon here.
That's great. Thank you both for that overview. Um, we talked a little bit, and we can, yeah, thank you. In terms of the pain points before the integration, Carla, you touched a little bit on it as far as what the catalyst for change was. I know at Glooko we saw similar trends that you described. So the data on the right there is really what we saw at Glooko. So you'll see right after that pandemic, a little leeway time for us to all get back to sort of normal. But then there was a significant increase in the number of remote uploads. And I think that probably resonates, Carla, with what you're sharing in terms of what your catalyst for change was. Um, Anything else you would add there? We talked about just the growth of those telehealth visits. Carla, anything else that really was that catalyst for you wanting to move forward with the EHR integrations?
Yes, it's basically the burden of the work during clinic time, right? Multiple devices to download with different platforms that you have to go through every time. It was a lot of work on our medical assistants, and then not just downloading from different platforms, but then they have to print, label every single report, and they are like very stack of pages and then in order for us to document this in the patient's chart, so they would have to scan the reports in the EHR system, copy, and then the provider would have to copy and paste data into the clinical note, or if preferred, type into the data, and then, or in some cases, manually input data in flow sheets. So, and in the end of everything, you have to dispose all those thick, reports. So really burdensome for documentation. And sometimes if you're typing it, you might not be typing correctly. So I think integration of EHR would lead to increase in safety, decreased time, more time that we have with our families, our patients, instead of being documenting this, right?
Yeah, and I think what you share is something that we hear with most of our customers before EHR integration. I think these challenges resonate. Chris, I'm sure you probably see similar challenges with your clinical teams. Do you echo kind of these same concerns? Anything you'd add about the clinical pain points here?
No, I mean pretty much the same concerns here, being a very large and high volume clinic and institution. When you have a lot of patients coming through the door and an inefficient system, we have patients on every pump, every CGM, every meter. So utilizing all those different platforms to download devices causes delays and issues and dissatisfaction. So echo all these. I think the one that I would add into there is, we're very, as everybody is, but we have a lot of we we focus on security for the patients quite a bit, and
Mhm.
some of the other platforms didn't quite meet some of our requirements. So one of our big things was finding somebody that can download these devices that met our
Right.
security requirements and kept everybody safe out there.
Yeah, no, that's a great point. Yeah, patient security. I mean, we all know, having worked in healthcare, that really is a paramount concern. Yeah, thanks for that insight. Um, so as far as the clinical pain points, let's move on to some of the operationals. Because Chris, from your lens, I'm curious what you observed from an operations lens.
Yeah, so I mean, our process, the patient checks in, they go, we have a dedicated intake bay where the vitals are checked. That's where the downloads occur, and then they're roomed. So in that intake period, that's where a lot of the inefficiencies were with different devices, trying to find the proper cord to hook up to that device, finding the proper system, getting your login for for that platform, performing the download, and then taking that report, saving it, imaging it into the media tab, so on and so forth. So that's a very long process. It's a process that human error just naturally when a high volume occurs. So, that led to kind of delays getting the patient into the room. Maybe the data wasn't in the right place or they didn't have the proper report downloaded. So it just led to there's various different, inefficiencies that happened there that needed to be addressed.
Yeah, thank you. Carla, I see you shaking your head, and I'm thinking about my last visit when I was at Rady Children's and all the work that your team had done just like to address what Chris is talking about, just to address all of the cords. Do you want to walk us just through what your team did? Because there are a lot of cords, as we all know, with diabetes technology.
Yeah, I even had a picture, our how the our we like Chris is saying is the same at Rady's. We had the little hub or like island hub where we do all the uploading of every single device. But before we used to have multiple cords and it looked really messy. And after Glooko, you have just like one nice little clean cable and so much easier. So much more efficient. And of course, in the provider side, when we document, now that this is integrated into our electronic health record, is basically one click for us. So,
Yeah, and that's a really great transition. So, yeah, thank you both for sharing your perspectives on the pain points. It really does echo what we hear from customers. When we talk to operational leaders, they echo, Chris, exactly what you're talking about. I know in all my conversations I've had with ops leaders, you're thinking about the patient experience from the moment they enter that front desk, and how do we improve that experience? And then things just kind of back up. And Carla heard the same things from providers. So yeah, I think what you're sharing really is representative of what we see across the country. Let's shift more into how the workflow changed and what some of the improvements were that you both saw. So Carla, we'll start with you. We spent some time reviewing some of the process changes, and they were pretty significant. So walk us through how the process used to work and what were some of the changes.
so thank you for putting this in here. So as you can see, first patients are checked in the front desk, and then the MA would take the family back and take the vitals. At the same time, they would collect all the devices in the exam room, and then MA would have to download one by one according to different platforms or cables, print that report, get it ready so the provider can have that report before just before seeing their patients. And of course, in order to document that, either scan a PDF, a printed version, um, and the provider would have to finally have to manually document, either copy and paste or manually inputting numbers. And after that, after when we underwent the integration, so the MA takes the vitals. At the same time, the device data is automatically synced into the EHR, because we have the Glooko dashboard over there, and our patients are already onboarded. And we can review complete data pre-visit. And now this doesn't need to be printed. You have the PDF in your computer, so you can see in color, and you can show to your families in color, right? Because normally when we print, it was like black and white. And And with the integration, one of my favorite things is really our flow sheet, and we develop a smart phrase into. We use Epic, so it's .Glooko. So we go in our documentation, our notes, you just do .Glooko, and it gives you all the main metrics that you need for your documentation right there in less than a second. And we can even compare because we receive data every week. So we can compare different weeks or different months. So right there in front of you, you can compare timing range from last visit to this visit to the even a visit before. Um, and so multiple manual steps were eliminated with Glooko platform.
That's great. And I love that you're sharing about the smart text. I think that's one of, if I had a favorite EHR integration, I love them all equally, but if I had a favorite, I frequently cite the flow sheets just because when you combine that discrete data with some of the native functionality that our EHRs have and really more of these sort of smart features, it really expands the capabilities, I think, of providers to deliver their clinical care. So at least, and it sounds like you found that power too, the power of combining the discrete data that Glooko can bring in with the smart text from your EHR.
Yes, and I would like to add that this allowed us to share the discrete data. We are part of a large collaborative to improve outcomes for people living with type 1 diabetes. And it's very important to have the data, discrete data, so you can share and you can use this for benchmarking, right? Because you need to know where you are to know where you're going and to really, and knowing those numbers and how you are in terms of your clinic in comparison to other centers in the country allows you to really decrease any inequities that otherwise you wouldn't know about.
Oh, that's great. I'm just kind of curious, before you had that discrete data, what was the process like to be able to share that data, or was it possible?
So you would have to enter manually.
Oh boy, that's a
Yeah,
lot of data.
have to. It's a lot of time. Yeah.
That's great. Chris, I know when we were kind of chatting before, I think the process flow that Rady's did is probably pretty similar to what uh, some of the changes that you were able to make at Michigan. Is that accurate?
Yep, that's accurate. Patient checks in at time of device upload to Glooko. That's when it generates the report flow sheet and sends it into the media tab and synopsis into Epic. So it's all right there for the provider to see.
That's great. So let's talk about some of the let's go to our next slide here and talk a little bit more about. So we've talked about the process, the before, the after, and you've talked a little bit about some of these. Tell us a little bit more about some of the efficiency gains that you saw at Rady Children's, Carla.
So now we're able to use remote monitoring for our patients when we're having telemedicine visits, or if we're on call at night, we have access to their reports if we need to look what's going on so we can help them. Of course, standardizing the download of multiple diabetes devices, it's a game changer for us. So in decreasing the time that the medical assistants also have to spend, going from one platform to the other. Having the automatic deliver of PDFs that are going to be in that patient's chart forever. So if you ever want to go back and see why do I do that? What happened last visit or the previous visit to now? The PDF is going to be there without having to print anything. And reducing manual handling. And then, of course, as Chris mentioned, increasing patient safety and clinic efficiency, and decreasing the time in documentation. That for me is major because it allows me to spend my time really taking care of my patient and the family and talking to them instead of having to go back and spend, a good amount of time just in documentation of numbers. So this is very interesting. We're mentioning, you asked me once, what is the time that we actually save?
Yeah.
So this is it's a very like ballpark
Sure.
estimation, and I think we're pretty we're actually very nice in this estimation. So before having Glooko, you spend at least this is just on the provider side, right? Not even counting what the MA time is. But the time that it takes for a provider during the visit to have a report and to and then after reviewing your report, talking to your family, you come back and you sit down and start completing your note. So how you're going to input those numbers there? So either you're going to copy and paste, you use can do snips, and copy into your note, or you're going to start typing all the metrics that you need. It's about 5 minutes per patient, or 5 minutes per chart. And if you take in account that we have about 4,000 visits of every year at Rady's for just type 1 diabetes alone, and among about 12 providers, and you spend 5 minutes per visit with that documentation, this is about 20,000 minutes, which turns into about 2 weeks a year, right? It's 2 weeks that we're saving. So it's about one full day of vacation that we could give to each one of us, just
That's
not having,
incredible.
yeah. So it's just to have an idea, really a ballpark, but it's interesting to think like that. The time and
Yeah,
efficiency. Yeah.
that really is incredible. And, probably like a true operator, Carla, I asked you, well, are you going to pack more visits in there? Like, let's pack some more visits. But you said something I love, which is you really are making sure that that time bolsters the wellness of your physicians. And I know we have such shortages in for endocrinology and really across the board that really preventing burnout is key. Do you want to share a little bit more about that? I love your philosophy on that.
Yes, and this is very personal also, but I have many colleagues that spend a lot of time in prepping charts for before they see patients. So this facilitates their life, right? Or even during the visit. And if you have more time to spend with your patient, I think you're going to increase your happiness with your job because that's what we're there for. We want to talk to our patients, we want to provide education, we want to talk to the family, and not so much time just charting, right?
Yeah.
So if we're happier doing what we do, we can provide better service, and we can increase wellness and decrease burnout among providers.
Yeah, I think this is, we hear the phrase a lot. I hear it a lot in nursing. I also hear it with physicians is that we want to work at our top of license. How do we keep working at top of license? And I think this is a great example of just how you've been able to reduce that administrative burden from providers, even 5 minutes at a time, to really allow them to have more meaningful conversations with patients, because that is exactly what we need our providers to be focusing in on. So yeah, thanks for sharing that, Carla. Chris, let's move over to you. I know you and your team have really done some incredible improvements as well, and gained some great efficiencies at Michigan Medicine. So walk us through what you've seen at your organization.
Yeah, so kind of similar themes here, but specifically our intake process, getting patients kind of from check-in into the room reduced significantly, 15 minutes a patient, as you can see there.
Wow.
And then that 3,668 patients, that's unique patients that had an upload to Glooko throughout the year. So you can even multiply that out more by reoccurring visits from those patients, if they come a second or third or fourth time throughout the year. So there's even more time saved there.
Mhm.
But that's really allowed us to make our intake process extremely efficient. And you'll see that as you move down to the second point here, staffing efficiency. Before we had all these integrations, we had three dedicated intake MAs that their job was to do downloads. And we've gone from three down to one, and that's been through attrition. But as we lost a couple of MAs, and as everybody has, hiring challenges and shortages
Yeah.
in the endocrinology world, we found that we can make this work with one MA a day and not have to worry about rehiring a second or a third MA. So it makes us, more efficient. We save that time, but we also save on 2 full FTEs. So that's both patient satisfaction, obviously the bottom line, which is always talked about, and um, which kind of moves me to this third one of paper savings. And this wasn't a glucose specific initiative, but coincidentally, at the time we started working on the integrations, our institution wanted to push us to kind of go paperless and along with, making our process more efficient. So naturally, this
Mhm.
Glooko fit in very well to that, and we estimated we save about $30,000 a year on paper and printing, getting rid of these reports, and we couldn't narrow it down, line by line what it was, but
Sure.
obviously Glooko at this volume with these large reports significantly contributes to that savings. So those were three efficiency savings, made leadership happy, uh, has satisfaction to the physicians and the patients. And then the other point that's not on here is as our remote offerings have expanded, through COVID and through um, just patients needing check-ins between visits, Glooko, all these
Yeah,
integrations, instead of the patient having to manually send us their information, which, sometimes doesn't happen or there's errors there, we have access to their data 24/7. So it's made video visits, but also urgent calls much easier.
that's great. And it sounds like are those things that you're able to just switch to kind of like fairly quickly because you do have the data, or walk us through a little bit more kind of how you operationalize that, the video
Yeah,
visits.
so we have video visits. They operate similar process to, an in-clinic appointment where we have an MA kind of going in, making sure the data's there, if not getting a hold of the patient. But, we have access to their data at time of appointments, and we kind of, have a similar flow that the physician's able to look at the data before and go through it with the patient at time of appointment. But
Okay.
for those urgent calls, yeah, we have, if a patient's like, I've been high for 3 days straight, it won't come down, or I have urgent lows, whatever the issue may be, they can call into the clinic, be triaged by a nurse. And at that point, we can get into Glooko or access Glooko via MyChart. MyChart's our Epic instance. Um,
Mhm.
and we can see the patient's data right there. So instead of having, asking, okay, what's this, what's that, send us this information, we can just go in and see it right there real time, and be able to triage and treat the patient as needed.
That's great. That probably saves so much time just with the messaging. And we haven't talked about this really, but from a patient's perspective, I chatted with several patients that before the integration, they would oftentimes have to print out their own logs and then scan them
Mhm.
via email, via MyChart, and then you're pulling them out. Like there's a whole process on the patient we haven't really talked about. But it sounds like this really allows just even eliminate that process from the patient and have those real meaningful conversations.
Exactly.
That's great. I want to dive in a little bit more into this staff efficiency. And as you were talking, one of the things that I was thinking about is, we're seeing, I mean, so much of our diabetes care is managed in primary care. And one of the things that we hear, at least in primary care, is that there aren't as many staff to do to do the data downloads. Specialty clinics are staffed different. And so I think what you're really are describing here is how the efficiency to do the work really can be done with a limited number of resources. Even, I mean, you're in an incredibly busy clinic.
Mhm.
Um, so yeah, that's great. Does that
Absolutely.
sound right? Am I like making the right connection there for primary care?
Absolutely. In primary care where they might not have the dedicated MAs to perform the downloads or the intake process, the information is there in Glooko. So it's especially as more and more devices go to the cloud-based and Bluetooth sharing. Once you
Hmm.
have your primary carrier at least in our world, they're more CGM where um, pumps are coming through our clinic. But our primary care, if you're seeing CGMs, that flow of data from that CGM to Glooko is happening 24/7. So all
Yeah.
the provider has to do is do the one click into Glooko and they can see the data.
That's great. Maybe just one more thought here, and then we'll move on to the implementation. But, Especially for accountable care organizations, and I mean, I think all organizations right now we're looking at how do we decrease the cost of care. But Chris, I think when you and I had talked before, some of these paper savings were, if I'm remembering correctly, they were really also aligned just with that overall expense reduction. Is that right?
Exactly. Yep. As I mentioned, it was a initiative we had for, you know, both environmentally friendly, but also expense reduction.
Yeah.
So moving into these integrations really helped us to meet some of those goals without having to worry about making harder decisions elsewhere that things necessarily that you don't want to cut or might affect the patient a little more. So
Yeah.
this
Yeah.
allowed us to meet those goals pretty easily.
That's great. Thank you. Let's switch over into adoption. And I think one of the questions that we hear a lot at Glooko is, okay, it sounds great. Glooko sounds great. How hard is it to implement? How long does it take to implement? There's a lot of questions around implementation. And Chris, I really love how you have approached just the overall implementation project at Michigan Medicine. And in fact, it's a model that we've shared with other organizations just as they're involved in the planning processes. So walk us through this particular framework and really how it guided your approach to implementation, as well as maybe helping to inform some of the timelines that you came up with.
Yeah, definitely. I guess the first thing I want to note here is most of these greens are now blues. So I think the only outstanding item is the create patient account thing on the top
Oh,
right
that's
here.
great.
Um, Standardized Glooko across all past and present locations. We keep adding locations, so that's always going to be
Mm,
ongoing. But
yeah.
other than that, we just have that one integration left. But excuse me. Yeah, but to speak further about this, obviously we're a big institution with a lot of priorities, a lot of clinics,
Mhm.
and IT resources are always, no matter where you are, stretched thin because everybody's coming at them with, I want this done now. So what we did was looked at all the available options that we could do with Glooko, both integrations and also internal workflow items, and made this little chart about what's high impact, to our operations and to the patient, but then or what's low impact to our operations and patients. And then to implement these, what is a low effort and what's a high effort. So, high impact, low effort, obviously that's low hanging fruit and that's stuff we got to work on right away. Anything that's high impact, high effort, that's something we want to do. And then we are able in turn take this, go to our IT resources, go to the resourcing meetings and say, hey, this is what we want to do. The Glooko team was great in providing, man hours needed and how long this integration would take. So we are able to take this chart, to provide and have a meeting with our IT folks to say, okay, this is going to be this number on our list to integrate, in the institution, and here's the time it's going to take, here's when it's going to start. So it really helped us, to be able to plan out our project as a whole, kind of look into the future, and then, set expectations for everybody about, what we're going to do, when we're going to do it, and how long it's going to take. So it really, instead of kind of sending one-off things to our IT
Yeah.
team and our leadership team, it allowed us to really plan the scope throughout the future, and we had everything aligned and were able to execute because of that.
Yeah, that's great. I love this framework, and I imagine, I mean, you talked about it. I imagine the IT team were huge fans of this because I mean, everyone is trying to get on the agenda, right? Like we're all trying to use our
Exactly.
limited resources. So I think this is great. What are some of the things that you found during implementation that seemed to work really well?
Uh, I think really anytime with implementation or, in multiple counterparts, you know, within internally our organization, obviously you had our IT team, then you had our operations team on the ground. So you had coordination there. And then you have the Glooko in part of this, and then some of the intermediate, like redox or whatnot, that's something might have to go through. So there's a lot of pieces to coordinate, and proper communication and coordination is essential for these to obviously get it done, but get it done in the time allocated that you have because otherwise they're going to go to the next thing. So
Yeah.
I think the communication that we had with Glooko, with our team, with our internal IT team, and some of these other teams that were necessary outside of Glooko and Michigan Medicine, it was great. You know, everybody was on the same page. If there's an issue, we were able to hop on meetings relatively quickly. So, you know, that coordination and communication, I think, it was essential to making this work and being able to get to where we are now.
Yeah, that's great. And then I know in healthcare, we're always looking at continuous improvement. What were some of the lessons that you learned along the way that you just maybe modified a few things what were some of those lessons learned along the way?
I'll stay out of the IT stuff. 'Cause I think they can speak better to that. But I think operationally is, you know, anytime you're moving to new reports or new integrations, you know, we have a lot of providers in our institution, and obviously everybody has a preference of how they want to see stuff. You know, and moving to this integration, you have one report that now everybody sees. So you know, we moved to the integration probably a little bit quicker than we should have before gathering feedback.
Mm,
So now all of a sudden the providers were seeing, well, I want to see this something simple as I want to see it in this color versus this color, or you know, why is it displayed this way? So I think gathering feedback, that essential feedback first,
mm,
showing like, hey, this is what the report's gonna look like once rolled out, versus doing it on the you know reverse. So I think, you know,
yeah.
working with the stakeholders and what they're going to see and how it's going to affect them a little earlier could have been useful,
Mm,
but ultimately we were able to work through that and, you know, get had some meetings, figure out what people want to change and made those changes, but would have been a tad more efficient if we did that up front.
that's great. Carla, I saw your head nodding when Chris mentioned that each of the providers have their own report preference. Did you encounter like a similar challenge when you were rolling out?
Yes, and I echo everything he just said. And it's very common. Everything you're implementing something new, you always have the early adopters and you have the late adopters. And I would 100% did exactly what
Hmm.
Chris is saying is bringing all stakeholders much earlier in the process because the late adopters, they have very important feedback. We need to listen to them and also, show the benefits much earlier to the whole team. So I would definitely encourage whoever is starting this process now. Um, of course, you have to have a champion, a clinical champion that can translate what the
Hmm.
clinical, expectations are to the IT team that are going to be working on that integration and together with the Glooko team or Redox team. To have someone from the clinical team that is going to be sitting on those meetings and is
Hmm.
accessible very quickly, so you move fast, but also bringing everybody in the team from one, for example, decided one medical assistant champion, one nurse educator champion, and one physician champion to be part of this team because this is not
Yeah.
just implementation now, but it's for the sustainability. Is going to be training floats, training new nurses that come in, or new MAs that come in, or new providers that come in. So it's an ongoing process in order to be sustainable.
Yeah, there really is that science to implementation for like the long-term success. Yeah, Chris, thanks so much for sharing this. Has been really helpful. I wish I would have had this type of framework when I was rolling it out at my previous organization because I love this. Carla, I'm curious from your perspective, just being in a pediatric hospital, what were some of the implementation considerations that maybe apply just to pediatrics or that were unique to pediatrics?
So we learn many things when we're doing, right? We're implementing this, but depending of the state you are, so we're in California, because you are now onboarding a minor, there are a set of questions that need to be sent. First of all, the minors sometimes don't have their own cell phone, right? So they need to get one, depending
Yeah.
on what kind of device we're implementing, or they don't have their own email or password. So
Mm,
this and depending what we are thinking, that needs to happen, and it needs to go through the parent. So when we are onboarding a minor, there will be an interchange of emails for the parent to approve and send back. So sometimes that might make things a little bit tricky, and you have to do part of the onboarding a little bit later. So we're
Mm,
really excited about the patient account management right now, because I think this is going to
yeah.
really facilitate if we need to move the onboarding a little bit later, when family has a cell phone or create the passwords the way they want to, you know, uh, have the child's account.
Yeah, that is really great insight. Our little ones that get diagnosed so early, you don't think about needing an email address for them when they're that little. So yeah, that's great insight. Um, just sort of in a general, we've talked a little bit about some of the lessons learned. I'm curious what recommendations you have for folks who are maybe considering moving towards an EHR and doing EHR integrations, or they're at the beginning of the process. What recommendations do you have? um, maybe that you haven't already talked about. Chris, we'll start with you and then Carla will come back.
I would say one of the key things I would look at is if you're an institution with multiple locations, to go out and survey those locations and get a feel for
Mm,
what their workflows are.
yeah.
Because, we have multiple locations and our main hub, if you will, we do things one way, but other sites might do things slightly differently. So really understanding how those different locations go through the intake process, who's going to do the work, um,
Mhm.
and understanding how they do it, I think is key to coming up with a successful integration and workflow plan for these projects.
Yeah, that's a really great thought. Did you notice that you were able to like maybe group like clinics together, maybe if they were more rural or more urban, or were you able to find some similar themes, or just kind of
Yeah,
curious?
some similarities across clinics, but as Carla said, one of the big things was for sustainability and identifying clinics that had maybe a little more volume or a little more structured like us, that we kind of had the MAs that were dedicated are going to stick around a little longer. That could be those centers of truth that another clinic that might have a lot of high MA turnover, we can send them to this clinic and get them up and running and trained pretty quickly. So. I think for the sustainability side, that really helped a lot.
That's great. Thank you. Carla, what recommendations do you have for folks?
My recommendation, I already touched on that a little bit, but is really even before the integration, is to put together a champion team, including
Mhm.
the medical assistant, nurse educator, and a provider, and listen to the group, what's important to them, and also show them, because sometimes people are not thinking, they're just thinking the today, right? And how it works in the day by day. But this is really, you have to have the vision where diabetes care is going. And remote monitoring is here and is going to allow us to be, as we said before, no longer reactive, but proactive. So we can establish different cohorts of in children or adolescents that, for example, are the newly onset diagnosed, and we know that they're going to have changes in their insulin dose very quickly. So instead of having the family calling us all the time, we can establish using now this dashboard that we have and remote monitoring to be more proactive. If we see someone is really, experiencing severe lows, you have to call them. Um,
Yeah,
Another thing, and another thing also, the kids that are struggling with diabetes management, we can help them. We can give extra resources if we're able to have access to real-time data. So
I
I
love
think
that.
there are so many points that can be brought to the team uh,
Mhm.
to have everybody on board.
That's
Yeah.
great. Yeah, those are great points. Um, to wrap up this discussion portion, and we've talked about a lot, and it is so great to hear how many clinical improvements you've seen, patient experience. We've touched on provider efficiency and helping to reduce provider burnout. I mean, we've talked about a lot. It's been great conversation. If you had to narrow it down to the biggest game changer for you or for your organization, just in being able to provide the future for care delivery, what would that single biggest game changer be, Chris?
That's a really good and tough question because there's a lot of benefits as
Yeah.
we've talked about, but I think probably the biggest game changer is how it's made, what's the right word to say here? It's made delivering care easier. With between staffing, if you might have staffing issues, or, if you're on the primary care world with all these new things coming out, you're
Hmm.
busier and busier, have more things to think about. So as we kind of continue along, and while all these changes, not just in diabetes care, but elsewhere in healthcare are great, it's adding more and more and more onto our care teams. So anything we can do to make it easier to get the data and put in front of the provider's face is having a huge impact in how we deliver care.
Yeah, that's great. And Carla, before we jump to you, we also want to hear from the audience. So you'll be seeing a poll launch just to get your thoughts. Where do you think the biggest impact might be? And then we'll revisit those. But Carla, what's been the biggest game changer for you?
Um, well, I have to say, for the provider point of view, absolutely is decreasing time in charting.
Mm,
Is decrease the burden of documentation. I think for me, that's the game changer. However, you have to see at the patient side is increasing the time that we have to spend with them, is increasing safety. And now with the dashboard, that's going to improve care for sure.
absolutely. Yeah, that's great. Thank you. Thank you both so much. Um, we'll give a few more minutes on that audience poll and we'll move into our Q&A session. And thank you so much for those of you who have asked questions. We will get to as many as we can, but we're happy to follow up with any of you if needed. So the first question is there a possibility of expanding which devices or pumps that Glooko can upload? Specifically asking about Tandem, Twist, and Medtronic. And again, echoing having one platform for all devices would be very helpful. So I can take this one. So at Glooko, we are always looking and working with our vendors to get more devices onto our platform. Tandem Cloud is now on Glooko, which is great. I know there are many people that were excited for that, but we are already having many conversations. I think the other nice thing in terms of devices is that because Glooko is a global company, there are many devices that are currently available in Europe that have not actually gone through the FDA approval process here in the United States. So we're a great way to get those devices on early. So I guess the short answer is we are always working with our device partners there. Okay, let's see. So another question is making reference to that time saving slide. They love seeing that. Have you also found a reduction in errors due to the removal of the manual steps? Carla, you want to take that one?
Yeah, absolutely. Especially if you're typing before, typing your timing range, your, average blood sugar, standard deviation, all of those that we need for different reasons in the note, that
Mhm.
there's no reason to double check or triple check if type in the correct number.
Yeah. The other thing that I would add too, I see there's a lot of I think most of the platforms have a copy and paste feature, which we do as well. I think that when you're pulling the data directly in, you eliminate that risk point of copying and pasting the wrong patient's data into the wrong chart just by an accidental disclosure there. So that's something that I've certainly seen as I've been talking with folks. Chris, anything you'd add to that?
Um, no, I mean, I think, yeah, we've definitely seen a decrease in errors. I can't quantify it for you, but yeah, it's definitely helped reduce any kind of safety concerns.
Yeah. I think, anecdotally, I think in healthcare, we're at least, I worked in quality for many years. We're always talking about variability. And anytime you can reduce variability of processes, you're going to improve your patient safety. So, I think about, Chris, you talked about all the numbers of papers that are in the office, and I've seen these stacks of, these all these printed papers. I mean, just eliminating the risk of even uploading one wrong sheet of paper to the patient is reduced just by removing that variability. So, yeah, a little more, I'd agree, it's a little more difficult to quantify, but we certainly know that we're reducing those risk factors. Okay, here's another question. So, um, I'm not in an endo office, but a diabetes educator for many different providers in another location. I'm mostly looking at the Omnipod 5 Glooko data. I'm printing and then scanning into Epic. Is there a way that I can import not from the patient in front of you, but from your Glooko system directly into Epic? I adjust the patient's pump every week. So I think this, and Carla, I'll finish reading this, but Carla, maybe you can address this. So they adjust the patient pump every 2 weeks until they're at goal. Then I monitor them every 1 to 2 months for a lifetime if they fall out of goals. A lot of paper, a lot of ink. Not sure how we'd make changes without the side-by-side data that the provider was talking about. Is the side-by-side data only available when the patient is right in front of you? Can you walk through? I think they're referring to the smart text that you talked about with that comparable data um, for your patients. And then I can add some things too.
So, so there's different ways you can use that. Of course, during the clinic visit, because the pumps from our Glooko system, they are uploaded into our EHR once a week. So when they come to clinic, we're going to see the last upload, and that, but we can see the PDF, the immediate PDF at that day if we do the one click. Otherwise, it's going to be maybe 2 days earlier, or 3 days earlier. So there's different things. And when that data, it automatically feeds into the flow sheet during the day of the visit. And so during the day of the visit, when I go and I click my .gluco, I'm going to have the last upload within the past 1 week. Now, if I have in between clinic visits and I'm calling the family, or the family is calling to review insulin pump reports, I can go and just click in one click, and that's going to pull the data from that day. And the PDF is automatically saved into the electronic health record. So we don't need to scan and input that into media anymore. Not sure if I answer your question.
Thanks, Carla. Yeah, I would just add quickly to that. Carla touched on the cloud to cloud, so that data can come in. But we also have the option within Glooko that you can send an order. So if you need to see the patient, they didn't have an appointment, they weren't scheduled, you can also pull the data via an order that you can just run, and it will automatically pull it in. We tend to see that a lot if providers talking on the phone to a patient, and then they need to pull a report in, and then they need to do some documentation. So there's a variety of ways that we can address that. And honestly, probably the best way is to just certainly schedule. We'd encourage you to schedule some time either with your current Glooko rep or with one of our demo team members. We'd be happy to walk you through that. I think we're running short on time. One question that just came in, and Carla, I think you spoke to this a little bit, but has anyone leveraged the data integration to proactively identify patients who are struggling with their control and worsening, and servicing those patients to the care team for prospective engagement? And Carla, you've mentioned our risk dashboard. Do you mind answering that question?
Absolutely. So we are working on this right now, because we have a team of case managers and care navigators that we follow and we provide resources exactly for that cohort of uh, individuals that are struggling with their diabetes care. And so we do provide outreach. And so using that dashboard, we can create, a risk stratification and we can create lists with specific individuals that we are following, or our case manager or care navigators are following. And we have team meeting discussions, monthly or twice a month to see what to do, and if those kids are what kind of adjustments they require. So absolutely, it's a work in progress, but we are taking advantage exactly of that resource that Glooko has provided now with the dashboard.
That's great. And our chief medical and chief strategy officer is really focused, as am I, on making sure that we can provide the tools, the data, and the resources for organizations to really support proactive care. We are at time. There were some great questions that we didn't have a chance to follow up on, but we certainly will follow up. We're happy to send responses to those to your questions. Carla, Chris, thank you so much for your expertise. It's been a great discussion. We really appreciate your partnership at Glooko. You are really doing some great things. And again, thank you so much to everyone who took time to join us today. Thank you all.